Hello, everyone. My name is Sheila Kanyimo, and I'm honored to be speaking at FMFZim Foundation Zimbabwe platform today. As a final year radiograph student at University of Zimbabwe, I have had the opportunity to work with many expectant mothers and their unborn babies. So this opportunity granted me the permission to carry out my study on the relationship between placenta crate and uterine artery Doppler in FGR babies. Basically, this is the overview of my presentation. Much of the work has been said already. So placenta crating, when we are saying placenta crating, it means we are evaluating the placental maturity based on sonographic appearance of the placenta. Crating helps us to determine if the placenta is functioning properly and if there are any potential risk to the fetus. So cranium classification is the common system used to create placenta maturation. As shown on the diagram, cranium classification categorizes placenta grades into 4 categories, grade 0 to grade 3. So basically, grade 0 placenta appears before 18 weeks. The placenta is smooth chorionic plate and it is homogeneous in echo texture. Grade 1 placenta usually is found between 18 to 29 weeks. It shows randomly distributed calcifications and subtle indentations of the chorionic plate. Grade 2 placenta usually found between 30 to 38. Now, on grade 2 placenta, we found multiple calcifications that are present in the chorionic plate, but they do not extend to the basal plate. Grade 3 placenta shows hyperechoic lines reaching up to the basal plate, large calcifications and indentations that are more pronounced in both the chorionic plate and the basal plate. So, grading of the placenta helps us to see the function, if the placenta is functioning properly. So this cranium grade is used specifically in normal pregnancies. Therefore, if we encounter mismatched grades, particularly the placenta before 36 weeks, this signifies the possibility of placental insufficiency. So, as already mentioned before, maternal vascular malperfusion is the most common cause of placental insufficiency. So it is important to assess the uterine arteries to see if they're functioning properly. Abnormal uterine artery Dopplers can be an early indicator of placenta insufficiency, since it is the one that supplies nutrients and oxygen to the fetus through the placenta. Basically, the placenta grade and uterine artery Dopplers are both important measures used in obstetric ultrasound to assess the health and well-being of the fetus. So the main objective of my study was to determine the relationship between placenta grade and uterine artery Doppler in growth-restricted pregnancy. And the sub-objectives was to determine the proportion of FGR pregnancies with abnormal placenta, as well as the proportion of FGR pregnancies with abnormal uterine artery Dopplers. My study was a retrospective study conducted by collecting data on growth-restricted pregnancies from 2 fetal medicine units in Harare. A total of 500 pregnancies diagnosed at 20 to 36 weeks diagnosed with FGR at 20 to 36 weeks gestational age were included in the study. The data was analyzed using this SPSS software, and ethical approval was granted by the Joint Research Ethics Committee. Here are the results of my study. I found that about 72% of FGR pregnancies are predominated by grade 3 placenta, that is the abnormal placenta. Since my research was focusing on 20 to 36 weeks, so appearance of grade 3 placenta signifies the possibility of placental insufficiency. On uterine artery Dopplers, the mean, about 7% of the mean uterine artery Dopplers were normal in my case. And when I used the right or left uterine artery Doppler, I found that about 66% of the uterine Doppler were abnormal. Therefore, I categorize my data into early onset and late onset fetal growth restriction. And on absolute numbers, I found that placenta.
Sorry about this. I think the slides were not moving. We correct this in a second. Sorry about this. Let's we're going to correct this. And Sheila might have to just restart quickly. We have the time for her to just go through the presentation again for the benefit of everyone in the meeting. Share.
For that, so this is the outline of my presentation. As I said before, placenta grading, we are evaluating the placenta maturity based on the sonographic appearance of the placenta. And this helps us to determine if the placenta is functioning properly and if there are any possibility of risk to the fetus. So the most commonly used grading system is the Granum classification that categorizes the placenta grades into 4 grades. That is grade 0, 1, 2, and 3. So basically on grade 0 placenta, our placenta appears smooth on the chorionic plate with homogeneous echo texture. Grade 1 placenta, the placenta appears with randomly distributed calcifications and subtle indentations on the chorionic plate. Grade 2 placenta, we found multiple calcifications that are present on the chorionic plate, but they do not extend to the basal plate. Grade 3 placenta, we found diffuse hyperechoic lines reaching up to the basal plate. There are large calcifications that are both appears on the chorionic and the basal plate. So knowing placenta grades helps us to determine if the placenta is functioning properly and if there are any risk to this. So where mismatched grades, particularly the appearance of placenta grade 3 before 36 weeks, gives us the suspicion that there could be placental insufficiency. As alleged before, maternal vascular malperfusion is one of the common causes of placental insufficiency. Therefore, uterine artery Dopplers must be assessed to see the pathophysiological of the placental insufficiency. Normally, in early pregnancy, the uterine artery Doppler shows high blood flow resistance, which gradually decreases as pregnancy progresses. However, in growth-restricted pregnancies, the uterine artery shows persistently high resistance, which is an indication of impaired blood flow to the placenta. This will usually lead to the placenta insufficiency. So abnormal uterine artery Dopplers can be an early indicator of the placental insufficiency. Therefore, placenta grading and uterine artery Dopplers are important measures used in obstetric ultrasound to assess the health and well-being of the developing fetus. So the main objectives of my study was to determine the relationship between placenta grades and uterine artery Doppler in growth-restricted pregnancies. The sub-objectives of my study was to determine the proportion of abnormal placenta grades in FGR pregnancies, as well as the proportion of abnormal uterine artery Dopplers in FGR pregnancies. So my study was a retrospective study conducted by collecting data from on growth-restricted pregnancies from 2 fetal medicine units in Zimbabwe, Artery. A total of 522 pregnancies that were diagnosed with FGR at 36 weeks gestation were included in the study. The data was analyzed using SPSS software, and ethical approval of the study was granted from Joint Research Ethics Committee. These are my results of my study. I noted that about 72% of placenta grades were abnormal in FGR pregnancies, and about 57% of mean uterine artery Dopplers were abnormal in FGR cases. When I used either right or left uterine artery Dopplers, I noted that about 66% of the cases had abnormal Dopplers. I categorized my data into early onset and late onset FGR, and on absolute numbers, I found that in early pregnancies, there are a bit small percentage of abnormal placenta grades and abnormal uterine artery Dopplers. However, the p-values were not calculated to see the statistical significance of the difference in these data. Moving on the association, that is the correlation between placenta grades and uterine artery Dopplers, I found that in early onset and late onset placenta grade, the association between placenta grades and between abnormal placenta grades and abnormal uterine artery Dopplers were not statistically significant. However, when I calculated on overall cases, I found that the mean uterine artery Doppler and placenta grade, the association is not statistically significant. However, when I used either right or left uterine artery Dopplers, I found a statistically significant relationship between the abnormal uterine artery Dopplers and abnormal placenta grades. So this tells us that placenta grade and abnormal uterine artery Dopplers are independent predictors for fetal growth restriction. There is an insignificant association between abnormal placenta grade and abnormal mean uterine artery Dopplers. However, as I said before, a statistical association between abnormal placenta grade and either right or left abnormal uterine artery Dopplers was observed. In conclusion, knowing the relationship between placenta grade and uterine artery Dopplers helps us to stratify those pregnancies that are at high risk and those that are at low risk. Knowing the high risk group helps us to monitor the surveillance and the surveillance of the pregnancy, determining the time of delivery and also the mode of delivery. So I recommend that placenta grading and uterine artery Dopplers must complement each other in the assessment of fetal growth restriction rather than to be used interchangeably. Okay, I would like to acknowledge Fetal Medicine Foundation Zimbabwe to give me this opportunity to present the findings of my study. As well, I want to acknowledge Parenya Group of Hospital and Salim Gabe Hospital Fetal Medicine Unit staff for helping me to carry out my study. Thank you so much.
Thank you so much, Sheila, and well done. Now is the time for questions. If we go through the chat box, I think Prof asked the question, should we promote routine placenta histological palsy and legal challenges? I was discussing with my histopathology colleagues before he left for another meeting. He was of the probably is a correct thing to do, because this may help in terms of the cerebral power of the medical legal challenges that come with poor neonatal outcomes. But we may hear from the other panelists here what they think, because it's important that we hear from the other panelists what they think of this. Then is umbilical cord hypercoiling a placenta problem or an isolated umbilical cord problem? Again, I discussed this question with our histopathology colleagues. He was of the opinion again that if it was isolated, in his own view, there is no poor neonatal outcome associated with this. But if, of course, if there are other associations, he would consider it a problem. So yeah, but we are open to other panels. Then any other question we have, either you can raise your hand to speak, or if you're a panelist, you can unmute yourself and speak. If you are not a panelist, please type your questions in the chat box so that they can be responded to, considering the 3 presentations that have taken place. Yes, Prof, please go ahead and speak. Professor Nicolau has raised his hand. You may go ahead, Prof. Prof, you wanted to say something, please go ahead. So there's a question from Dr. Dragana here. She is asking the histopathologist who has just left on why Lancet, the local laboratory in Harare, why they're not doing histochemistry. Yeah, why they're not doing histochemistry when they have it. They promise to come. Maybe we'll ask him to respond to this and type in the chat box when he comes back. Very good question. Then I think on one of my slides where it should be 4 centimeters on the placenta thickness. Please take note of this when you go through the slides again. On